Welcome to our third episode. This is Care for a Healthy You. This month we will be discussing pain management in elderly patients. At the end of our time together, we hope everyone has a better understanding of pain management and how our rehab services can help. Hi, I'm Chad Waterman, the Assistant Administrator here at Care One at Lexington. I'm here with Dr. Asapur. She's the geriatrician at Mount Auburn Hospital. She graduated from Harvard Geriatric Fellowship Program at Beth Israel Deaconess Medical Center. She's been practicing geriatrics at Mount Auburn Hospital for the last 3.5 years. Welcome. Thank you for your time.
Thank you so much for having me.
Today we're going to discuss pain management in elderly patients. Dr. Asapur, what is the prevalence of pain in geriatric population?
So first of all, I want to be clear that geriatric population means people over age 65 years of age. Definitely the pain incidence is much more common in geriatric population compared to younger ages. And the reason is that, as we age, because of the pathophysiology of aging, we will have more wear and tear in our body, especially in our musculoskeletal system, our joints and muscles. There are twofold increase in painful conditions as we age. We see lots of osteoarthritis of the joints in our geriatric population. There is a high incidence of falls in geriatric populations because of gait disorders. As a result, we have more orthopedic surgeries for knee replacement, hip replacement, and fractures. So definitely we have more pain after all those surgeries and operations. So based on literature, the prevalence of pain is about 50% daily pain in geriatric population. At nursing home setting, because we have people with more comorbidities, multiple medical conditions, functional decline, definitely the incidence of pain is higher in patients at rehab and nursing homes.
Great. Why is it important to diagnose and treat the pain in the elderly? The consequences of untreated pain in geriatrics, as we know, is number one is direct suffering. They will suffer from the pain. Mm-hmm. Sometimes they cannot really verbalize the pain, the concerns, so that's why it's important to diagnose it sooner than later. It can affect their function. They will decrease mobility, decrease normal functional activities. It can cause over time depression, social withdrawal, not participating in social activities. It can affect their sleep. We have people who have sleep disturbance because of pain. Sometimes, again, in geriatric population with dementia, it's hard to tell why they cannot sleep. Otherwise, we think about pain. It can increase health utilization, increase lengths of stay in the hospitals, lengths of stay in the rehab, and overall causing increase in financial burden of the society. Got it. What are some of the barriers that you encounter during your diagnosis in the elderly?
So in terms of barriers, we can pretty much put our geriatric patients in two groups. One is patients who are cognitively intact and they can tell us about their concerns mm-hmm. and complaints. So in this population, the barriers we have in terms of pain management is because they most of the time they have other comorbidities, both the patients and the families, or even we see most of the time even care providers, the physicians are reluctant about starting pain medications with concerns about adverse drug reactions or causing more delirium, confusions with these sort of medications. The other part would be they think that they are too old for managing pain and they can tolerate pain at some level. In patients with cognitive impairment, like patients with dementia and stroke who have aphasia and they cannot really verbalize their pain, the barrier is how to diagnose the pain
Sure.
in this population. Unfortunately, there's a misperception between families
and some of the providers that, in demented patients, they cannot feel the pain the same as other people, or probably nothing can be done for them.
Great. Do you think the pain in all patients with Alzheimer's is ever underdiagnosed or undertreated?
As I mentioned, that's one of the big, really barriers in terms of diagnosis pain in this population, because they cannot really verbalize if they are in pain, and if so, how much pain they have.
Right.
So as a geriatrician, that's our job really to assess the pain in this population and try to manage it. The way that we assess the pain in this population, because they cannot really verbalize, we have sort of tools, what we call observational tools to assess the pain in this population. Pretty much there are some pain behaviors that we observe in these patients. So we have tools at nursing home that we pretty much educate the staff, the nurses, about how to use this tool and how to notify physicians and nurse practitioners about any of these signs when they take care of these patients. For example, some of the pain behaviors that we have is like facial expressions, like grimacing or tightened face, open mouth, based on the facial expressions. Vocalizations, like if the patient's moaning, groaning, crying, or particular words that we use, type of breathing, breathing heavily. Again, sort of body language, body movements, not using part of the body, or limping, or clenching, those sort of things, and the changing mental status in terms of if the patient become agitated, aggressive, combative, patients who used to be calm and interactive and social, changing social behaviors, changing daily activities, or change their routines, like patients avoid going to the social activities, to the dining room, those sort of things, then that's alarming signs that something is going on.
Gotcha. After you've made this diagnosis, what are some treatment options that you offer?
That's a great question. So in geriatric population, what we do in addition to medical management, we definitely think about non-medical options, non-pharmacological options. We definitely want to have physical therapy, occupational therapy, and exercise as part of our pain management. We use lots of topicals, both physical modalities like warm pads, ice pack, and pharmacological like topical ointments, creams, compounds, or even injections. In terms of systemic management, we usually start with over-the-counter pain medications. My first choice, and usually geriatric first choice medication, is Tylenol or acetaminophen at a dose that is acceptable, or other type of over-the-counter medications. We monitor the patients on these medications in case the patient has really acute or subacute pain after surgeries, or moderate to severe pain that's not responding to all these modalities. We will start the patient on narcotics, but keeping in mind, because of the physiology of aging, their liver function, their kidney function is not the same as younger people. So usually our principle is to start low dose and go slow, and monitor and titrate the medication.
What are some major differences between the pain management in the elderly population that you see and younger adults?
As I mentioned, as we age, because of the pathophysiology of aging, our absorption, metabolization, excretion of the medications will not be the same as young patients. Definitely our kidney function and liver function is not the same. So that's why we want to make sure we have the right choice
of the medication for geriatric population, monitor their liver and kidney function on these medications, and start at low dose and really go slow with very close monitoring.
Great. A lot of great information. I just want to say thank you for your time and your wonderful knowledge, and thanks for being with us.
Thank you for having
Thank
me.
you.
Thank you.
Welcome to Care for a Healthy You. This is Rudy, the Rehab Director for Care One at Lexington. I am a doctor of physical therapy. Therapy plays a vital role in managing and overcoming patients' chronic pain. We use interdisciplinary approach and evidence-guided treatments in dealing with pain and managing the pain. So primarily the basic function or role for therapy in managing the pain is to reduce the pain and improve the function. We have two different approaches in dealing with and managing the pain. It can be passive or active approach. When we say active approach, the patient is part of this intervention, just like exercise, massage, could be guided imagery, relaxation techniques, or any more activities. But we can also use passive approaches, which uses physical agents or use of electrical modalities such as electrical stimulation, ultrasound, and diathermy. There is always a misconception that if patient is in pain, the patient should not be doing any exercise or should be not moving at all. This is definitely wrong, because basically patients that are not moving, are not exercising, are more vulnerable to pain. Based on research, actually, it is recommended that patients that are in pain should be doing exercise. And this kind of exercise should be slowly started and should progress slowly as well. So what kind of exercise it should be? It doesn't really matter what kind of exercise for dealing with pain management. It could be active exercise, a passive exercise, aerobic exercise, strengthening, or even exercise or using the bicycle or treadmill as well. As long as this exercise is slowly started and slowly progressive, it's okay for the patient. We have to remember that these exercises help build the strength of the patient, increase flexibility of the patient, stabilize the joints of the patient, and of course increase activity tolerance for the patients. Those exercises could increase blood flow to the muscles, and if there is increased blood flow to the muscle, that will reduce the pain. Here at Care One at Lexington, we use different physical agent or modalities in treating the pain. We use electrical stimulation. As I said a while ago, we use ultrasound and diathermy. So let's discuss each one of these modalities. So let's start with electrical stimulation. The first machine is electrical stimulator. This is an example of electrical stimulator machine. So basically this machine delivers low voltage electric current to the muscles, and that muscles also stimulate the nerves to block the pain signals. So this is the electrode, and we put it in the patient's skin, and these are the channels. We have A and B channel for this machine as well. So there are two theories why this kind of machine helps reduces the pain. The first theory is, it says that once electrical stimulation or stimulus has been detected by the nerves in the skin or the muscles of the patient, it will send signals to the brain to block the pain impulse or pain signals. And also it's been stated by research that once the muscle receives this electrical stimulation from this electrode, it will naturally produce natural painkillers, which is what we call endorphins, and these endorphins will kill or reduce the pain sensation and the muscle as well. Electrical stimulation could be set up in a different wavelength, frequencies such as a steady flow of electrical current or a burst electrical current and intensity of electrical current. The sensation felt by the patient under the skin will send signal to the nerve and to the brain to block the pain signals. That's it. Ultrasound is also used in managing the pain for patients here in Care One at Lexington. Actually, ultrasound has been used since 1940s with the physical therapists. This is considered the oldest physical agents used to deal with pain management. So ultrasound uses a rounded probe, which is in direct contact with the patient's skin, and using the gel at the surface of the probe in order to decrease friction between the metal part of the probe and the skin, as well as to increase transmission of the ultrasonic waves to the patient. Therapeutic ultrasound is in the frequency range of about 0.8 to 3 megahertz. The waves are generated by a piezoelectric effect caused by the vibration of crystals within the head of the wand or probed. The sound wave that passes through the skin causes a vibration of the local tissues. The vibration or cavitation can cause a deep heating locally through usually no sensation of heat will be felt by the patient. In situations where a heating effect is not desirable, such as fresh injury with acute inflammation, the ultrasound can be pulsed rather than continuous transmitted. Ultrasound can produce many effects other than just potential heating effect. It has been shown to cause increases in tissue relaxation, local blood flow, and scar tissue breakdown as well. The effect of the increase in local blood flow can be used to help reduce local swelling, decrease the pain, and chronic inflammation. The intensity or power density of the ultrasound can be adjusted depending on the desired effect. A greater power density, measured in watts centimeter squared, is often used and always been used to decrease the pain as a goal. Another machine we use for pain management is using diathermy. This is the diathermy machine. The diathermy machine produces heating sensation to the skin, which is a deep heating sensation to the skin. It can reach as much as 2 inches from the skin surface. The diathermy machine does not apply heat directly to the body. Instead, the current from the machine allows the body to generate heat from within the targeted tissue. As the heat increases, it promotes blood flow. It also can help improve flexibility in stiff joints and connective tissue as well. With decreased pain and inflammation, patients with arthritis or any pain-related injury can increase their range of motion. This may allow them to move more easily and participate in rehab more comfortably. According to American Geriatric Society panel on chronic pain in long-term care setting, it states that chronic pain in long-term care setting are undertreated and underrecognized. It is a misconception to say that pain is a part of normal aging process. If pain is assessed well and have the right intervention, it will be managed well and could increase the patient's quality of life. Once again, this is Care One for a Healthy You.
Hi, and welcome to the nutrition segment of Care for a Healthy You. I'm Jocelyn O'Brien, the clinical dietitian at Care One at Lexington.
And I am Carol Huff, the Assistant Food Service Director.
And today we're going to cook some salmon with you. Salmon are packed with omega-3 fatty acids, protein, and vitamin B. And omega-3 fatty acids has a lot of properties in helping with pain management, anti-inflammatory properties, and also helps with brain development. So our recipe today is a sesame salmon, and the ingredients that you will need will be
Soy sauce.
So soy sauce, you always want to try to find an option that is lower in sodium if you can. It always will be labeled on the front and says less sodium, so that's always the option that you would want to go for.
The second ingredient you will need is mirin.
So mirin is a sweet wine, and today we replaced it with sherry, and you can also use any kind of other white sweet wine that you have on hand.
The third will be chicken broth.
And chicken broth, again, you want to go with the lower sodium options.
Honey.
Honey you can get either at your local farmer's market or at the store.
Garlic.
And garlic, we chose again this time to go with the freshly cut garlic that's already minced, saving you some steps into the preparation, but you can definitely use also the fresh garlic.
One more ingredient is going to be ginger.
So the fresh ginger, you can get the ginger fresh, grated, or again we found this ginger that's already grated, fresh, that you can keep in the fridge and redo this recipe again easily and quickly. So these are the ingredients that you will need for your glaze. And you also need a couple more ingredients to cook the salmon. So we have fresh fillets of salmon that are about 4 ounces each. And the skin, we did keep the skin on for cooking. Our next ingredient is
1 large egg white.
So we're going to show you how to separate the egg whites if you don't feel too comfortable doing that.
We also have sesame oil.
The sesame oil that we used at our last food demonstration as well has a nutty flavor and has a really nice taste if you're going with more Asian style type of cooking.
And lastly, sesame seeds.
So sesame seeds you can get either toasted or not. This recipe calls for toasted sesame seeds. If you have them on hand that are non-toasted, you can just throw them in the oven on a cookie sheet, toast them until they're golden brown. So we're going to start our first ingredients. So we're going to start by taking about 3 tablespoons of soy sauce. If you don't have a measuring spoon at home, you can use just a regular tablespoon. If you use a little more, a little less, it's really up to taste. Then you use about 2 tablespoons of your sweet wine. Mix it in a saucepan. And then about a half a cup of low sodium chicken broth. Nicely mixed together. And we're going to use about a half a teaspoon of honey to add a little sweetness to it.
Okay. Interesting.
So a little half a teaspoon of honey. So it's about 1 teaspoon of grated ginger. And then mixing it all together. And for the last ingredient in the saucepan, we'll use about 3 garlic cloves minced, which 1 clove equals to about a half a teaspoon. So we'll do a teaspoon and a half of garlic. If you love garlic, you can definitely use a little more.
I do.
And then we're going to set this aside, mixing it all together, set it aside, and in another bowl, we'll whisk cornstarch and water. Now the cornstarch and water is to add a little more thickness to the glaze that we will need later. And then in another bowl, you will whisk together the cornstarch and the water. So you need about 3 tablespoons of water and about 2 teaspoons of cornstarch. Whisking it together again. And if you use warm water, usually it dissolves a little quicker. Whisk it together and set it aside. Now, we're going to be preparing the salmon. So to prepare the salmon, we're going to need an egg white and some cornstarch in a small bowl.
In order to get an egg white, you want to crack the egg. I'm going to play with it for a little bit and try to just keep the yolk right inside. And if you do happen to get some egg yolk in there, just use a spoon to scoop it out.
And the egg white is actually what's really rich in protein, so it adds a little more protein to your recipe. Now we're going to mix the egg white with about 2 tablespoons of cornstarch in a small bowl. And what we'll do with that mixture is we are actually going to brush the salmon skin down with the egg mixture, and we're going to sprinkle some sesame seeds on top. So we're prepping the mixture. And if you don't have a brush at home, is there anything else they can use, Carol?
Yes, any kind of flat spoon, just to lay it over and spread it across.
Looks good.
At this point, I'm going to lightly brush the salmon with the egg white and cornstarch mix.
So you do that for all your fillets. And if you happen to have another different cut of salmon where it's more of a flat surface, you want to do it skin down to really get on the flesh of the salmon. Other fish that are also rich in omega-3 fatty acids, which help with inflammation, include fresh tuna, trout, halibut, shrimp, and also beef is a good source of omega-3 fatty acids. So now that Carol brushed the salmon, she's going to sprinkle it with some sesame seeds. And what we're going to do after is gently place the fillets, the seed down, and cook until the seeds are golden brown, which is roughly about 5 minutes in the pan. And now we put the sesame oil in the pan, which is about 1 tablespoon, and heating up the oil a little bit. Once it's heated, you can smell the nuttiness of the oil. And gently, with your hands, place the fillets, or tongs, place the fillets in the pan.
Are they supposed to be
Seeds down, yeah. Because that's so you want to put sesame down, and that will indicate when the sesame seeds are turning golden brown that your salmon is ready to be turned.
Smells delicious.
Now once the salmons are in the pan, you're going to wait about 5 minutes to get a nice flavor a nice pan searing. A lot of the recipe for salmon can also be done in the oven if that's easier. You can definitely do that as well.
If you see that the sesame seeds and the oil is too hot, you can turn it right down to a medium-low to finish cooking. 5 minutes is a pretty good time, but there's also another way that you can tell that the salmon is ready to be flipped is when it's a lighter pink, a little bit more than halfway.
And now you flip the salmon fillets over. Nice golden brown with a nice crunchiness to it.
Really good.
And also, if you see some white droplets, a lot of people will not eat the white droplets. They're actually where most of your omega-3 fatty acids are. The white droplets on the salmon, as well as the brown flesh that is closer to the skin. So you turn it around and you should leave it for about 3 minutes. And like Carol said, the flesh is starting to be lighter pink. You can see that it's getting to be a little more firm. When you pick the salmon at the store, you definitely want to be picking a salmon or any fish that's shiny, that doesn't smell too fishy, that the odor is low, and that's cold and that it's firm. You want the flesh to be firm when you pick a fish at the store. So we'll let it cook for about 3 minutes. So today we're cooking 4 fillets of 4 ounce each, and 4 ounces is about what you need for a meal, a serving. What you could do is you could do the 4 fillets together and save some, put it on over a salad, keep it in the fridge once it's cooked, and put it over mixed green and do a nice salad with it. Or you can have it warmed up in the oven or in the microwave and have that for a luncheon, or put it in a sandwich on a whole grain bread. So now Carol is going to remove the fillets from the pan. So we're setting the salmons aside. And what you're going to do is you're just going to take your pan that you have your soy sauce mixture in. I'll take that from you. And heat that up. So we're going to heat this soy mixture up until it simmers. And once it starts simmering, you can see that little bubbles are actively bubbling in there. So that's definitely what you want. And you'll add the cornstarch mixture to thicken that glaze. So the cornstarch and water that we mixed over, we'll add that.
Mix it just to make sure that the cornstarch sticks in with the water.
And stirring constantly for about 2 minutes, and you'll see it thickens fairly quickly. So 1 minute is really what it takes. We have a strong heat today, so probably a little less than a minute. And once that's over and ready, you gently spoon the glaze over the fillets, and it's ready to serve. Each fillet is about 290 calories, about 15 grams of fat. That may sound a little high, but it's all the essential fats and healthy type of fats that you need. And it has about 27 grams of protein. So gently spooning them over. Some foods are also fortified in omega-3 fatty acids like eggs, juice, milk, or yogurt to get another good source of those essential fatty acids that you need. So we hope you enjoyed cooking with us today, this delicious sesame salmon recipe, and we hope to see you next time.
Enjoy your salmon.
We hope to see you next month. Thank you. It has been another great episode of Learning and Knowledge. We hope to see you on our next episode. This is Care for a Healthy You. Welcome to our third episode. This is Care for a Healthy You. This month we will be discussing pain management in elderly patients. At the end of our time together, we hope everyone has a better understanding of pain management and how our rehab services can help. Hi, I'm Chad Waterman, the Assistant Administrator here at Care One at Lexington. I'm here with Dr. Asapur. She's the geriatrician at Mount Auburn Hospital. She graduated from Harvard Geriatric Fellowship Program at Beth Israel Deaconess Medical Center. She's been practicing geriatrics at Mount Auburn Hospital for the last 3.5 years. Welcome. Thank you for your time.
Thank you so much for having me.
Today we're going to discuss pain management in elderly patients. Dr. Asapur, what is the prevalence of pain in geriatric population?
So first of all, I want to be clear that geriatric population means people over age 65 years of age. Definitely the pain incidence is much more common in geriatric population compared to younger ages. And the reason is that, as we age, because of the pathophysiology of aging, we will have more wear and tear in our body, especially in our musculoskeletal system, our joints and muscles. There are twofold increase in painful conditions as we age. We see lots of osteoarthritis of the joints in our geriatric population. There is a high incidence of falls in geriatric populations because of gait disorders. As a result, we have more orthopedic surgeries for knee replacement, hip replacement, and fractures. So definitely we have more pain after all those surgeries and operations. So based on literature, the prevalence of pain is about 50% daily pain in geriatric population. At nursing home setting, because we have people with more comorbidities, multiple medical conditions, functional decline, definitely the incidence of pain is higher in patients at rehab and nursing homes.
Great. Why is it important to diagnose and treat the pain in the elderly?
The consequences of untreated pain in geriatrics, as we know, is number one is direct suffering. They will suffer from the pain. Mm-hmm. Sometimes they cannot really verbalize the pain, the concerns, so that's why it's important to diagnose it sooner than later. It can affect their function. They will decrease mobility, decrease normal functional activities. It can cause over time depression, social withdrawal, not participating in social activities. It can affect their sleep. We have people who have sleep disturbance because of pain. Sometimes, again, in geriatric population with dementia, it's hard to tell why they cannot sleep. Otherwise, we think about pain. It can increase health utilization, increase lengths of stay in the hospitals, lengths of stay in the rehab, and overall causing increase in financial burden of the society.
Got it. What are some of the barriers that you encounter during your diagnosis in the elderly?
So in terms of barriers, we can